Just have to enable transcripts. Voice memo.
It's okay. I'm wearing a cat shirt with pizza on it, even though this is being recorded.
Totally fine. Truly, the recording is just so that I can transcribe it on the other side.
Yeah.
All right. So it is a bit of a scripted interview. So it should flow mostly like a conversation or discussion, but there are times when I'm sort of going to bring you back to a main question.
Okay.
So getting started, thank you so much for agreeing to join me for this one-on-one. As you've heard, the aim of this interview is to hear more about your experiences within the domains of equity, diversity, and inclusivity. Your participation in this interview is completely voluntary. If at any point you would like to step out, take a break, pause, and early, absolutely let me know. You're welcome to do so. This interview is recorded with the intention of generating transcripts that will be anonymized. So even if, names are mentioned or identifiers get thrown in there, they will be removed with the final transcript. So with that being said, do I have your consent to start?
Yes.
Excellent. And before we actually get started with the interview, do you have any questions for me?
Is it anonymous?
So it is anonymized, in the sense that your name will not be on it. Your largely identifying features will be taken out of it.
Right.
But depending on the anecdote that you share, there may be pieces that could be tied to you depending on the story.
Where will this be published?
It's my master's thesis.
Okay.
So it's not being published anywhere in that sense.
Other than the McMaster thesis repository.
The Maastricht thesis repository in the Netherlands.
Oh, great.
So on a different continent.
Excellent. So I can tell you all the juice. Okay.
Oh, please do. For the record, can you please state your age, your gender, and your role at the Cancer Center?
I'm 35. I identify as female. And my role at the Cancer Center is resident physician in radiation oncology.
Beautiful. So the very first question that is asked is to get you to define or explain 3 terms. So we will go through them each sequentially. So the first term that I'll ask you to define or explain is the term equity, in your own words.
So equity, I'm able to understand it as what it's not. So it's not equality. So equality is when everyone is given the same set of resources, whereas equity is everyone is given or not given resources or access to certain services or things or products, whatever, depending on their individual pre-existing, what's the word? I don't want to say characteristics, resources, I guess you could say, or opportunities.
Fair.
So that everyone ends up having equivalent chance at achieving a certain outcome.
Right. So it's more the individualized need as opposed to one size
a blanket. Everybody gets the same. Yeah.
Exactly. And the second thing I'll get you to define or explain is the term diversity.
So diversity is, when it comes to people, is the inclusion of a wide range of people based on gender, sex, ethnicity, culture, all those things, everything, sexuality, et cetera, all the things that make us who we are, as well as where we're from. When a group of people that are together, it's not homogeneous with respect to those qualities. It's varied.
Mm-hmm. For sure. And then how would you define or explain the term inclusion or inclusivity?
Inclusivity is, when it comes to people, is a cognizant and intentional behavior or attitude towards others, whereby they feel equal opportunity to be a part of a group or speak as a part of that group.
Mm-hmm. Fair enough. So keeping those definitions, those ideas in mind, do you see them having a role in influencing the patient-clinician interaction? And if so, in what ways?
So yes, each of these does influence the patient-clinician interaction. So I can start with equity. You want me to just go through the list?
Yeah, however you want to approach the question.
With respect to equity, do you want me to approach it from like how equity exists in the physician group versus what resources are available to provide to our patients specifically? Like I guess I could talk a lot about equity within physician groups. I could talk about equity with resource allocation to our patients. I could talk about equity with respect to like how different socioeconomic backgrounds of our patients lead to inequity in how they access healthcare or like how they present.
So I think because there is a later part in the interview where we touch on sort of your role within your division, within your department. So from this one, let's focus more on the interplay with you as a provider as it relates to you providing care for patients.
Yeah, okay. So the more equitable the selection process is for physicians, the more likely it is that a patient is able to be managed by a physician, more like in terms of their health care, that is more aware, I guess, of equity and how it impacts patient care. Whereas if you're a part of a homogeneous inequity kind of group, where that doesn't really matter, you will have less of an understanding of how equity impacts things, statistically speaking. Yeah, I could go on, but I don't know how detailed you want me to be.
I mean, it's the idea of when you, because obviously you've identified that yes, these domains matter in patient care. So to whatever fullest extent you want to explore the ways it impacts that clinician-patient relationship, I think those are very valid things to hear, and to really, really, explore within the parameters of this interview.
So I guess physicians, are, if they're a part of a group that physicians where equity is endorsed, they are more likely to have resources in their other physician colleagues in order to garner opinions, for example, during tumor boards or in any other setting where there's a multidisciplinary approach, or if you just need advice or an opinion from another clinician, that would help you optimize the patient's care plan. That's more likely to happen, and then that means better outcomes for the patient if they have a better care plan. So you can glean information from your colleagues if it's a more equitable group.
And so also having a wider array or perhaps more diverse opinions serves patients better because they get more eyes or more thought patterns.
More knowledge, like more heads put together that are not all the same thinking.
For sure.
For things that I may not consider or not know about. So it means that essentially gaps in knowledge are less likely when making patient care decisions.
And you had mentioned some earlier about like resources that are available. And so what did you mean by that? Can you explore that a little bit more?
So resources that are available to patients. So, so healthcare in Canada is largely more about equality than equity. So, for example, because my patient has a hernia, it matters whether they're male or female and how they got it, if that's covered by OHIP or not. So I don't know if you want me to give me like an anecdotal.
Sure. Yeah.
So like personally, I have like a bad hernia from carrying twins. It's not covered by OHIP to repair, even though it's quite symptomatic. These cases have gone to the Supreme Court before and been not passed. But if you're a man who is just obese and gets a hernia, it's covered. Yeah, so things like that. Like there's inequity in our healthcare system, which directly impacts what I'm able to offer my patient in terms of care. Yeah, and ageism too. Like if I have a really healthy patient who's just like a year over the cutoff for a certain chemotherapy or something, or like a stem cell transplant, I know that I don't think Ontario operates that way necessarily, but in trials they're not always included. And so then you're like left with the question of like, oh, are they represented in this trial? And if not, am I just propagating like ageism? So that, I guess that's another way.
Yeah. And I know that you had mentioned earlier that within the other domains, you had some other thoughts as well, you know, as it relates to diversity or inclusion. Were there other things you wanted to share?
Yeah. So inclusion, I think when I'll give an example for inclusion. So I think the pecking order or like the hierarchical, sort of paternalistic way that medicine is taught. I know that we're taught not to be paternalistic towards our patients, but within our own learning, it's very hierarchical, especially in internal medicine, for example, or surgery. I think that is very detrimental to patient care, and it can sometimes even be dangerous. So that attitude leads to residents and med students and people lower in the pecking order, even if they're full staff or nurses or what have you, feeling that they can't speak out when they think something wrong is happening for fear of like retribution. So, in med school, there was a patient who the resident was doing the surgery. She dropped the appendix and we couldn't find it in the patient's body cavity. And I was a med student and I'm standing there and I'm like, they should just fill the body cavity with water. But I was so scared to speak up. And I'm the type of person that is like the person who speaks up and like annoys people and it gets me in trouble. But like, I'm like, this is how I sleep at night. If I think it's right, but I didn't say anything. And then after, like, they had to open him up from like nip to navel, like, or like pelvis. It was so bad, and like searched him for so long. He was so sick after just a normal appendectomy. Finally found it. And then after the case, the surgeon went to one of his colleagues and was like, what would you have done? This was Dr. Bailey before he, I think, had a stroke. And, his colleague said, oh, I would have filled the cavity with water. And I was like, oh, I should have said something. But the resident I was working with who dropped the appendix, I wasn't afraid of Dr. Bailey. I was afraid of her. I don't know if you remember Val.
Yes.
She was really awful and scary. And she was a 5th-year resident, and I just did not like, she gave people bad evals. She would get people, like, she would fail people. She got Dr. Bailey in trouble for something that was like silly. So, yeah, like that attitude that's like nurtured and encouraged in medicine that people can get away with leads to poorer outcomes. Like if I had just felt that I could speak up, we would have avoided all of that, or potentially avoided all of it.
Yeah.
That's one example.
Oh my gosh. Yeah.
So that's the inclusivity, like failure, I guess.
Yeah. Well, that everyone didn't have an equal voice. Everyone wasn't given the space to feel like they could vocalize for the sake
of give an idea. Yeah. Even if it's stupid, just feeling like you're not going to be judged, especially when it's about a patient's like acute, like anything, like anybody have any ideas? Like I've been in ORs where the surgeon is just like, does anyone have any ideas?
Yeah. And then, because you're creating a space where people feel like they can step forward. That's hugely important. Yeah. So in that same vein, it sort of lends itself quite well into the next question, which is, have you yourself encountered or been a part of a clinical situation where these domains directly played a role in patient care? So, in their decision making, establishing trust, breaking bad news, like an oncologic example, for instance. Yeah.
So I think inclusivity at the Cancer Center, particularly in Hamilton, is very good compared to other specialties in medicine. From my own personal experience. So residents are often encouraged to spend a lot of time with the patients. And I think time is a luxury in oncology. We get an hour with each patient. Residents don't have to see every single new patient, so they can kind of spend more time with that one patient who needs more kind of TLC, and they can explore goals of care and patient, kind of backgrounds a little better than you might be able to in other parts, and we're encouraged to do so.
Mm-hmm.
So I think in certain disease site groups, that approach is encouraged because it directly impacts the patient's like care plan, in the sense that like, I have gone into a room and then done the consult, the staff comes in, they decide on treatment, everybody leaves, and then I just feel like the patient doesn't fully get what's going on, and I stay behind, and I'm allowed to, and I'm encouraged to if I want to.
Mm-hmm.
And then I suss it out with them, and it turns out like they don't want this treatment, it's not for them, blah, blah, blah. And then like everything completely is flipped on its head.
Mm-hmm.
And we end up doing better for the patient in the end.
Mm-hmm.
Or offering an alternative treatment that they didn't realize was better for them in their situation. So that's happened a bunch of times, and I've always felt okay about it in certain disease site groups, and in others it's not so encouraged. Like I can be specific if
yes,
you want.
please. Yes.
Yeah. So with particular staff. So like the CNS group in general is really good with that, but Dr. Witten, God bless him, is very old school. I love him, but he always does this. And this will give away his identity if you put this in the paper. I only do from here to here, he says. So if a patient who's sitting in front of me, and this really happened, has metastatic melanoma, we've treated their brain mets, and they have little nodules all over their body. They're little melanoma tumors. No one will tell them in that clinic what they are. Oh, just wait to see your med on. Well, they're all just popping up. What is this? And I'm just like, oh my God, like this guy, like, cause we controlled his brain disease. So we're giving him this good news, but the guy has like disseminated melanoma everywhere else. And I'm just sitting there and listening to this like interaction. And I'm like, this is insane. And like, how are you telling this patient that we've controlled his central disease because you're refusing to do anything outside of here? So I stayed behind, and I, in secret, told the patient, I'm like, that's melanoma, it's everywhere. Like, you need to call your med onc, and he was like, what's my prognosis? And I'm like, I don't know. I'm too junior, probably not great, but you need to call your med onc. Like, I don't know. That's when immunotherapy was really changing for melanoma. So I've been at the cancer center forever. And, so I didn't know for sure, but like, he was like, oh my God, like, thank you for telling me this.
Yeah.
Because he wasn't going to see his med onc for like a couple months.
Yeah.
He'd be dead by then. Right.
Yeah.
So, cause he wasn't on systemic therapy.
Oh God. And that's so hugely important.
Yeah. And so I didn't feel comfortable sharing that in front of my colleagues, but I felt compelled to do it anyways, which is why I get in trouble all the time, but it's okay. It comes with the job, right? We didn't pick this because it's like easy and because like we want to be best friends with everybody, even though that's nice.
No.
So, and like other disease site groups like gynae can get like that, although the rad-onc group has completely changed. So that's a lot better now. It was really toxic before.
Oh.
Yeah. The gynae group was, but now I find they're very, patient centric.
Good.
And like ideas are welcomed.
And so I guess this blends beautifully into the second part of this question, which is, have you borne witness to an encounter where, say, a staff or a senior or a colleague did not incorporate those domains well, did not acknowledge the individualities of like, domains of equity or diversity, and it impacted patient care that either resonates with you, or conversely, an example where like someone else did it brilliantly that you watched?
So I guess I'm trying to think of an anecdote that specifically addresses one of those three. Okay, so I was in a clinic where a female patient with no psychiatric history was very anxious about us doing like a rectal exam because she had had a very traumatic colonoscopy like a week prior. This was in St. Catharines when Dr. Okawara was still there. And so she finally let me, like, after speaking to her, I'm like, what happened? And she was saying that this, like, she felt like this physician who did the colonoscopy, like, she felt like she had been raped. And so I'm like, oh my gosh, like, that's a serious thing that happened. Like, have you complained to anybody? She's like, no, like, I don't want to think about it, like, da, da, da. And I'm like, do you have like a history of like sexual trauma? No, like no weird or like red flags in her history that would lead me to think that she's like making this up or overreacting or maybe having some sort of mental health episode, associated with it. That means that the physician didn't do anything wrong necessarily. So I was trying to like find reasons that maybe she's being oversensitive. But then I went back and looked at her medical records and I was like, this woman has no history of like accusing anyone of anything. She's very like adherent. She's very like just a typical regular patient, no like red flags in her history. And so I looked up the physician that did it and he has like a record. Yeah. Of like, and he's on, like his license is like, what's it called? Like when you have like, you can't do certain things and you're under the supervision of someone.
Restricted.
Restricted. His license was restricted. It didn't, it wasn't specific. It like, so I went and found the ruling from like, and he was like in the newspapers a while back for like, they were like sexual harassment stuff. And I was like, oh my goodness. I'm like, this could be real. This poor woman needs like, if she wants to like, she needs help, first of all. And anyway, so I told Dr. Okuwara and he told me to not be so judgmental and jump to conclusions about my colleagues. And so I was just like, oh my God. So I stayed late and spoke to her and I told her how to complain to the college. And, I firmly believe that the reason he didn't take her seriously is because he treated her like a hysterical woman, just being hysterical. And to me, that's like not inclusive.
No.
Right? Of like other people who are different than you, namely by like gender. Like, oh, women, when they complain about pelvic exams, they're just hysterical. Like I know gynae's hard and like, rectal and anal cancers in women those exams are probably a little more sensitive than they are in men, just because of biologically men and women are different and culturally too, right? The way we're brought up. So I think he didn't consider any of that. Even if she was like making it up in her head, she still needed help. I mean, so it just didn't sit right with me. I went to Dr. Strang and we like figured out a way to help the patient. But at the end of the day, like I couldn't reach out to the patient again because it would be something that I have to share with Dr. Okuwara. He wasn't okay with it because I brought it up again and I'm like, can I tell her like that she can like give her the phone number of the college or the whatever? And he's like, no, he told me not to. And I can't go against him, right? Like medical legally, I'm not allowed to go over his head. And it's just, what am I going to do? Tell on him, report him? And I'm like, I can't go down that road. So at least I gave her the phone number like initially. But anyways, that's an example of like.
That's so hard.
It's awful, eh?
That really is, within the confines of this conversation, at least, like that is so not taking the patient's needs into account. It's not acknowledging that this is a lived experience that they've gone through and it is directly impacting.
Whether you agree with it or not.
Yeah. But it doesn't matter.
It's impacting her care. She wouldn't let us examine her.
Like
I couldn't get a sense of like how far it was from the anal verge. Like I don't know what I'm treating. We just had to rely on the MRI, which is like good enough sometimes, but not always. I
mean, it's not standard of care to not be able to include that clinical examination as part of her workup.
So it definitely could have impacted her care.
For sure. That's hard. I can't imagine how challenging that was to have to go through, especially.
He failed me on that rotation.
Did he? Mm-hmm. Oh gosh.
Yeah.
So you had direct negative like repercussions of doing.
Because we butted heads a lot especially about MAID. He wouldn't like offer his patients MAID if they asked for it. He'd like pretend he didn't hear them. And I had like a problem with that. And I also did like a talk for like regional oncology rounds on MAID, and he was not happy about that because he's like a conscientious objector or whatever.
But because it misaligned with his own personal beliefs, he would not.
He wouldn't even like talk about it. And I remember being like, don't we have like a duty to refer? He's like, oh, well, like we'll see. And I'm like, so he just would kind of like turn a blind eye and just not address the question. kind of thing. So, I think if that situation was severe enough where I felt like the patient really, really did want to pursue it, like I would have just referred them myself. I didn't get the sense, so I didn't do anything about it in the end, but like that's how he practices. And I was just like, oh my God. Needless to say, he's also a Trump supporter. So I definitely knew from the outset that he was not interested in diversity or equity or inclusivity.
Yeah. But that also poses, and we'll get into this a little bit further in the interview, that poses a challenge, I'm sure, for you as an individual. Like, aside from you being a learner, but just you as an individual being in a space where perhaps you feel like you aren't able to vocalize your thoughts
absolutely.
or your perspectives because there is a hierarchical dynamic there.
Yeah. And I paid for it. Like
Yep.
someone, like working with someone who I know supports a political candidate who is a misogynist as a female is really tough. Like, I'm like, oh, like this person could never respect me if they like this other person. Like, it just doesn't align with any possibility of them truly respecting me as a person because I'm a female. So that was hard to deal with, and it probably did impact patient outcomes, but I tried my best, I guess, to minimize that.
That's so hard. That and I know that feels paltry, but it truly is. That's like an incredibly challenging.
It was a hard time. Like, I had to go to like therapy and stuff to like deal with it. And I thought that I was like stupid and that there's something wrong with me. I can't believe I failed a rotation. And looking back, I'm just like, you know what? After I passed my exam, I was like, I know what I'm doing.
Yeah. Like that's the validation. You're like, yeah, it didn't matter.
That's all the validation you need. Right?
So I am going to circle back to another question though. So, you've touched on a lot of incredible points and you've touched on a lot of very poignant anecdotes where a lot of these things directly played a role or were incredibly important towards patient care. In your reflection of your training, have you ever received any formal or informal training within these domains as it related to being a radiation oncologist?
Yes, like definitely in med school. We both went to MAC, so there was lots of that. But as far as rad onc, I would say, definitely there were some half days where there was like focuses on kind of like socioeconomic determinants of health. In regional oncology rounds, like we've had some good talks related to those topics. Yeah. Like
thinking back to med school, what were some of those training opportunities that you were given that like really stand out in your mind?
Like you could, if you wanted to do your family medicine rotation at the, like in Caledon, like in the First Nations reserve. I didn't take that opportunity. I was a little bit nervous too, because I know that there were some like whisperings in our class and the classes ahead of us and below us that like it's a tough rotation, and like if you're not native, it's going to be hard to like feel like you belong, which I understand, right? I just felt like I wasn't ready to do that. There was it was so long ago. So like there was a lot of pro comp stuff around like the code red zone. Like how to deal with patients who have different religious backgrounds when it affects, like, directly will impact their care because of it. Yeah, that's all I can think of off the top of my head. I'm sure I can think of more.
And then outside of your medical training, were these things that you ever learned about in your own personal life through other resources or opportunities that you sought out?
So I have a very interesting background in terms of being brought up evangelical Christian. I am now an atheist, not like Richard Dawkins, like atheist, more of like a Carl Sagan, like a nice atheist. I'm more just like, everyone can believe what they want to believe as long as they're not hurting anybody or themselves and not indoctrinating their children. But essentially I was brought up with, to believe a lot of hateful things. And it was easy to believe those things when you live in a predominantly white, homogeneous type town. I'm from Oshawa. I was probably the darkest kid in my school and didn't realize it. I was very homophobic, or like, although it's hard to say you're homophobic if you've never met someone who's actually gay. I was very opinionated. I was anti like choice. I don't like saying pro-life. I think we're all pro-life. But anti-choice, yeah, just a lot of bad things I was brought up to believe. And then I went to university and met a lot of cool people who fit into the groups that I was taught to hate. And so I started searching literature, books. I read all around like every topic, and it became very clear to me that I just was essentially brainwashed as a child, and that every like human has an internal value, no matter what their background, and even if you disagree with what they're doing, which I don't in any of those aforementioned scenarios, but like even if you do, you can still have compassion for people and treat them with dignity and respect, even if you disagree with them. So for example, I disagree with like Jehovah's Witnesses not wanting a blood transfusion, but I understand how they got to thinking that, and I respect it. And I also have a very like keen understanding of we are often victims of our circumstance and upbringing, and a lot of beliefs that people hold very dear, they were brought into and have never been provided with an alternative. And I'm not saying that if they were provided with an alternative, they would change their mind, but just that people don't just wake up one day and believe crazy things, right? Everyone has a very good reason for what they do, even if those things are horrible. And so I try to take that with me wherever I go. And I like to assume everyone is good unless they give me a reason to believe otherwise, no matter what they think or believe.
And so hearing you share that, was that hard? I mean, it may sound like a dumb question, but like, how did you grapple with the fact that you had lived with a certain worldview and changing it over? I can imagine that was quite uncomfortable and distressing at times. And so how did you feel? How did you keep with it, knowing how hard it was?
I think the mistake I made at first, because it was very difficult at first, because you feel like you're losing your identity. And then I realized I'm still the same person. And I still have the same like morals and values at the core of me. I really haven't changed much from then till now. It's just, I was like misled, but I'm still the same person. Like, I don't think I'm the type of person who, if given the opportunity to challenge my own beliefs, that I would just like reject any sort of facts brought to me. Like, I'm very like a truth seeker, and I've always been that way. I just don't think I ever had the opportunity to find the truth in the past. And then once I was out of the house and able to find truth, I accepted it. And I think had that opportunity happened earlier, I would have changed my mind a lot sooner. I just hadn't met anyone who were in these groups. I hadn't had any life experiences to lead me there, but I don't think that like something changed in me. I think it was just more the information I had access to, and people had changed. And so it was difficult at first, but looking back and as I grew up, I realized that actually I'm actually really just the same person. Which is gratifying in a sense, because it shows that people can change their specific views and opinions without changing like who they are. Like you aren't your opinions. I think we all have like values that are kind of ingrained in us, and they're pretty static, and it doesn't mean that you can't change your mind about things.
And that desire to seek truth, or that desire to learn and to discover, was that something that you were told that you had to do, or was it self-motivated? Knowing that you were, in a life space where things had been going quite well for a lot of times, what was the thing that prompted you to want to even shift?
I think having encounters with people that I truly respected, and we had similar values and yet such different opinions, was very like unsettling. how can someone think things that are so different than me and yet have such similar values? And I think even now that's not something that's abnormal. It's normal to have like I have friends who have very similar values and we think very differently on certain topics. Mm-hmm. But I think it was self-motivated. Mm-hmm. Honestly, it's kind of ironic. My mother, who is sort of the one who was the reason my family was brought up, like that we were evangelical, like she was the driving force. It wasn't my father. And she's still very, like full on drank the Kool-Aid, like Fox News. Like it's awful because she's such a lovely, wonderful person. She like volunteers in Africa, like she's a nurse. Mm-hmm. And she's retired now, but she still goes back to Uganda and other like Sierra Leone and places like that and just like gives her time to help people. And yet she believes horrible things. So I know she's a good person. Mm-hmm. But she actually told me when I was having these doubts about what I believed, she's like, go read up on it. Read all you can. Read all around the topics. And you like, in her mind, she's like, oh, and then you'll like settle on Christianity, evangelical, like conservative thoughts. And it did not go that way at all. I'm like, thanks, Mom.
Well, I mean, at least she encouraged you to seek truth, right?
Yeah.
In whatever way you could find it, so that at least you knew that you were encouraged to do so. Mm-hmm. So with that in mind, when you reflect in yourself, how comfortable would you say you feel when it comes to addressing or talking about these domains with your patients? And what are some, learning curves that you still have, things that you want to see yourself continuing to grow in?
So whenever I speak to patients, I guess I don't talk about like equity, diversity, or inclusivity. I more frame it as like, it doesn't matter who you are, where you're from, what you did, as long as you love me. No, I'm just kidding. But like that these resources are here. And if you need extra resources because of whatever reason, you just tell me and we'll figure it out. Like I let them know that like there's equity here. Even if it might not seem like it, you just need to ask for help. Mm-hmm. Because I'm not a mind reader. Mm-hmm. And I don't have all the time in the world to like follow you around and see what you need, to make your outcomes optimal. I also let them know that like, like if you'd rather have like a male social worker, or if you want to talk to like one of the male GU guys, cause you're like whatever, or if your religion like dictates that like you're having a woman doctor is weird, even though I don't agree with that. Like, I'm happy to like let you see one of my male colleagues. Like, it's your health. You're the one with cancer, not me.
Yeah.
Now is not the time for me to be judgy. So I do have those conversations when I feel that they're like needed, but generally every patient I see, I let them know that like, we're in this together. We're like equal parties. I know I'm the expert, and like, I tell them, I'm like, I don't tell my mechanic how to fix my car, but like, he shouldn't treat me like garbage because I tried to look up how to change my own brakes. Mm-hmm. So like if you have questions, like like it's very open. Okay. And I respect that that each patient is individual, and I let them know that in words. Mm-hmm. Yeah.
And then are there any things that as you look forward going into the rest of your career that you want to continue to work on, or things that you've recently reflected on that you want to continue to strive towards?
I have trouble with, this is like a transference, countertransference thing. I have trouble with male patients who are clearly misogynistic, and especially it's bad. It's because of my own like baggage, like males from the Middle East who like don't respect women. I have a really hard time. And the way I've gotten around it up until now is by just tough love. I'm like, well, too bad you're stuck with me. You don't like it? Go somewhere else. And I'm like, which I don't think is the best approach. It's worked. Like it ends up being like a love-hate relationship in the end. And it has worked out well, but I just don't want to feel that way about a group of people. Like, even if they are misogynistic, or maybe they're not, and I'm just pegging them as that because of my own like biases. So that's something I want to work on for sure. I mean, I'm half Pakistani, right? So it's really hard for me to like get outside of my own head because I know what people are like.
Yeah.
Like I have first-hand on the ground experience.
Yeah.
So yeah.
Fair enough.
My dad is a lovely person, by the way.
Feel like let the record show.
Almost never marry a Pakistani.
But I think that does segue quite well. So have you, and this is now exploring your lived experiences, have you been in a situation where the person on the other side that you were interacting with didn't take the time to acknowledge your diverse needs, your personhood, provide an equitable or inclusive space for you, and that affected you personally or professionally? Starting obviously with like oncology anecdotes, if you can draw them, but others work too.
In oncology, I many times by female oncologists, maybe in 2 situations, neither of which are at the cancer center now, thank God, told me very directly, like, because you have children, you can't don't think that you can use them as an excuse to get out of things at work. And I'm like, whoa, I never even mentioned anything about my kids. What are you talking about? It's like they were anticipating that I would use my kids as an excuse to get out of work and stuff like that. Which I'm it just made me feel that mothers of young children who are training are not a part of the club and are seen as lazy or something, or making stupid life decisions. That's what that kind of said to me, in other words. And they acknowledge that yeah, your life is more challenging, I guess, than someone without kids, which I don't actually even really fully agree with. It's just, I have different priorities, I guess, than maybe someone without kids. But, that was difficult and definitely led to me overworking myself because I felt like I had to compensate for the way that they saw me, even though I wasn't using my kids as an excuse for anything. I never would use them as an excuse. And even if I rightly needed to, say stay home to take care of one of them, I didn't. I would just call my mom to come do it. And she would drive 2 hours to get here. I would get my husband to cancel all his meetings, even though I don't even have clinic that day. Do you know what I mean? Because I was terrified of being labeled. So that's one example in oncology. At work, when I was an analyst before I got into med school, when my boss hired me, she was in her 30s. I was in my 20s. She told me, don't ever expect me to give you a promotion. And I said, why? And she said, because I'm a woman and you're a woman. And women just are catty with each other, and that's the way it is in the world. And I was like, oh, okay. Why did you hire me?
That's so bizarre.
Yeah, I've come across a lot of toxic female characters in work, but I've also come across a lot of lovely, strong women. I'm obviously focusing on the negative here because I feel it's important to call it out. But there are so many supportive women that I've come across, Dr. Strang, Kara Schnar, just so many strong women who have helped me through and given me encouragement as fellow females in a similar situation. And even Dr. Days has been amazing, and very supportive of being a woman in oncology with kids who are young. He's been very mindful of that. Something I've noticed with patients is, and I've brought this up before and had mixed responses. So another anecdote would be, and I know this all focuses around the female,
no, that's fair.
Not inclusivity, but
yeah.
I've noticed in breast cancer patients that we very knee-jerk reaction, want to give them reconstruction. And I'm just especially the younger women, and I'm you're kind of implying that they're incomplete without their breasts. I'm did you ever give them the option of maybe just not getting reconstruction? and being like, are you sure? Like, you don't want it? Are you okay in the head? And it's like, why aren't we telling our patients that, like, yeah, you can get it if you want. If you don't, that's cool too. Like, whatever helps you feel like better at the end of the day, because this is like another big surgery and there's complications and it can mess up your care.
Mm-hmm.
Like, how many times in radiation oncology do we see patients who have like spacers put in intraoperatively, and then we have to irradiate them and they get horrible toxicity and then their treatment is delayed? Like, that has got to affect their outcomes.
Mm-hmm.
Just so they can get like breast reconstruction. It just seems so, like, in other parts of oncology, I feel like we do not focus on that as much. Mm-hmm. For some reason, boobs have like this special status. I don't get it. Similar to like postpartum women. When I was postpartum, I got Advil and Tylenol. I was in excruciating pain. And I almost like hemorrhaged out on the table. Like, there were like transfusions, everything. It was bad. Like, they were almost going to call like a code. And, so I was in a lot of pain because they were like working on me to stop the bleeding. And my husband gets a vasectomy and gets sent home with Dilaudid and like Valium. Yep. I had to beg for like half a milligram of Dilaudid in the hospital because I couldn't like move in bed from the pain.
It's a subculture, right? It's a whole implied reflexive knee-jerk reaction. Be like, women
don't feel real pain. We're just hysterical. Black people don't feel pain, right? They're just loud or whatever, over the top. Yeah. It drives me nuts. The only group I would say where that's true is farmers. They feel like their pain tolerance is off the charts. So if they're in pain, they're probably dying. Like, if they're like, I'm kind of having a little tummy ache, I'm like, oh God, send them to the emergency.
No, true. Very, very true. If a farmer complains, get the CT right now.
Call the doctor. Yeah.
Yeah, for sure. So the last question that I have in this is, and we've talked about a lot of different things, but is there anything that we've not covered during this interview that you think is important to be said as it relates to the overarching research topic, which is trying to understand how oncologists learn and understand EDI?
How they learn and understand
the domains of EDI.
Right. Okay. Oh, yeah. So I think we're very good at pretending to implement EI with our patients. We give them all the resources they need. We publish about it and make ourselves look good. And then when it comes to each other, we treat each other like crap. And we do not practice what we preach with each other. Mm-hmm. We treat each other worse than our enemies sometimes. Mm-hmm. And it's really sad that we think we're so high and mighty that we're infallible and only patients need to stay home if they have are sick or have a cold. I go to work when I'm sick, mm-hmm. Because I'm a doctor and I'm so important. I'm stronger than my patients. It's so funny, the dichotomy, we give our patients all this, I don't even think it's leeway, but I think a lot of people think it's leeway for missing treatments or not adhering. We come up with all these reasons that they do that, but then, we're going into work sick, mm-hmm. either because we think no one else can do what we do, which sometimes is true. But if you have a follow-up clinic and they're all well, or I'm sure you have a colleague who can back you up, you're not God, they'll be fine without you for a day. Or you're scared of retribution, mm-hmm. because you know how your colleagues are going to treat you, mm-hmm. if you miss work or if you take pat leave or mat leave or whatever.
Okay. And do you think that culture is driven by something insidious, or is it just that people don't know better? They've not been trained better or taught better?
I think it's two-pronged. I think there's a bit of a selection bias in medicine. The type of people who go into medicine are a little more type A. Mm-hmm. There's a reason why I don't have a lot of physician friends. I don't fit in with them. I didn't want to go the pre-med route. I have a physics background. Mm-hmm. I stayed away from the pre-med kids. They freaked me out. They were so you knew who they were in the class. Is this going to be on the exam? Da, da, da. Mm-hmm. I didn't want to be a part of that. No offense to if you were pre-med. It's okay. You're an excellent doctor, Shivani, and you're like awesome. So don't worry. Like, not that my opinion means anything, but like, you are not a part of that group of people. And I was probably being way too judgmental, but, as a group, I've always been like, ooh, with doctors. So, I think there's a personality difference, like amongst the population of doctors compared to regular, like the general population. It selects for certain types of people who are like masochistic, a little bit Machiavellian, right? And high achievers. Yeah. But it also selects for people who want to help people. So you get a good mix in that sense. But I also think it's like the culture is from like the dark ages. And as much as we want to change it, like with the paternalistic approach to patients, which I think we've done a good job so far at doing sort of kind of compared to maybe like 20 years ago. But it's like we've forgotten that we do it with each other. And so I think that education piece isn't there. So in a perfect world, right? Like outside of the known realities, if you could make, like, cause you said it's about training and teaching each other to be better. How would you see it done on a sort of systemic level in a way that could actually be diffusely implemented? So I think little things. So for example, us not having to call our superiors Dr. So-and-so. We could just use their first name. I think that creates an atmosphere of inclusivity and gets rid of like the hierarchical feeling of things. I think little things like that can help create an environment where there's no like, I guess what I'm saying is like small things like that actually have a big impact. So there's like little things you can do like that. Also encouraging people to ask questions in the sense of when you are working with a staff, and it took me so long to realize this because I come from an academic background as well. Like I have a master's and I was going to do a PhD, but then decided not to. And we were like encouraged to like drill into each other's ideas and even like professors, like you're like, and like you got to defend your ideas. That's what science is. In medicine, if you like try to talk that way to a staff, you're seen as like challenging them or questioning them, which you're not. You're actually just trying to learn. So I think, like, they know more than you. Otherwise you wouldn't be asking them. And I think sometimes there's this culture of like when staff actually don't know the answer, they pretend like they do, or they treat you like you're being insubordinate. And I think just doing away with that altogether and encouraging like openness when we're in clinic or in tumor rounds. So instead of having like people like quoting papers and acting all like blah, blah, blah during tumor boards, like going around the room and giving people a chance like to talk, kind of like a kumbaya circle like we would do in pro-comp. And almost like forcing people to talk so that they don't have like an excuse of being too scared. And then it just becomes normalized. Like you have to like pick apart this person's idea. It's expected of you. Almost like at Mac, it's expected that you're going to give people feedback. So be ready, and you have to give feedback. It doesn't matter if you don't have nothing constructive to say, make it up. Like think of something. It's like, if that was the attitude at tumor boards, I feel like residents, med students, colleagues that are more junior to other staff would have to speak up. They'd have to say what's in their head eventually. If everyone gets a turn to speak. And is expected to speak. You can't just be like, oh, pass. No, I agree with the plan. So mandate everyone to have a voice so that you can entrench a system where everyone is comfortable having a voice. It's like poking holes in each other's shit. That's what my friends say. Like when we come up with ideas or something, we try to like poke holes in each other's shit because like that's how you come up with a good plan. Right? Is you find like the deficits and then you fix it. So really, like it's the idea of, equalize the space, because right now it's very unequal, and that the power rests in a very small group. And that in what I'm hearing is detracts from progress. It detracts from being able to give good care because you don't know what you don't know. I can't tell you how many times in tumor boards I know that my staff knows about the literature or like a certain paper is like nuanced and a decision is being made and they won't speak up because they're like, it's not worth it to like get up, like crawl up someone's back over this like small issue, which is going to change the patient's care. But it's just like, I get it. Like, do you want everyone, like people to hate you? Do you want to be seen as like someone rocking the boat? Which in our profession is like really frowned upon. I mean, look at like the H. pylori guys, like they were like ostracized. Look at, like dogma, like ways that we treat people will be accepted for so long, like different managements for different cancers. And everyone knows it doesn't work and we still do it because no one wants to like speak up.
Yeah.
Because like so-and-so published the paper and they're a big deal. And it's just like, like in academia, that would never happen. Like people love poking holes in each other's shit in grad school. It's like what you do. It's how you like get a name for yourself.
Yeah.
And it's fun. And it's in good nature. Like no one, you don't hate
if the discourse is wanted and it's productive and it's not in bad faith and that, you know, there's very much not a culture of that in medicine of accepting discourse as anything but bad faith. Right.
It's like, they assume the worst, I think. And I think what I've learned from my like walk through life up until now is always assume the best of people and you'll probably be okay. Cause I think most people have good intentions. And unless they give you another reason to not believe that, then just leave your mind open to the fact that maybe they're not saying this cause they hate you. Yeah. It's not personal. They probably are just like, oh, maybe your patient would benefit from this. Have you thought about that?
Yeah. Like, that it's not a fight against you. It's truly just to move towards a common goal.
And just, and like everyone, can we all just agree that you can't know everything?
Yeah.
And it's okay to not know the answer, even if you're like top of your field, like, like there's a reason why so many different specialties exist. Yeah. And that like rad onc used to be easy in like the 70s. You just take a beam and you point it. Yeah. Not even a beam, you take cobalt. And it's just grown so much. So like, when I ask like Dr. Strang something, she'll kind of get like sheepish and be like, I don't know. And I'm like, that's okay. The field has changed so much. I don't expect you to know this.
Yeah.
Or like they're not up to date on the most like recent breast cancer thing that was published yesterday. Like she's an amazing colleague and practitioner and she shies away.
Yeah.
Because of the system that she was brought up in. And that's like such a loss to me because she's so smart and has a lot of good ideas to contribute. And I see other practitioners go through it too. And they just keep their mouths shut because they've learned the hard way.
Yeah.
Or they see things happen to other people.
Yeah. So really it's about trying to move the needle forward where people feel not only comfortable to be vocal, but on the other side, people are comfortable with receiving that feedback.
Yeah. And and like almost creating a system where it's not just encouraged, but forced so that the environment is one in which this is going to happen anyways. Like I love how Mac did that with the feedback thing. I hate giving and receiving feedback, but it was like tough. Yeah. That's just the expectation. Yeah. And, I remember bringing that with me to, residency and it was received strangely for people who weren't educated at Mac. So I remember giving Dr. Dorsami feedback after he gave me feedback because I thought that's what you do. And he was kind of like, why are you telling me what you think of me? Like, he was like, are you on crack? And I remember just being like, oh, I really like the way that you do this with patients. And he was very like stunned. Like, how dare you like tell me what you do and don't like about what I do? Like, yeah. And then he almost like laughed it off, was kind of like he felt awkward. Yeah. But it's a funny position to be in when complimenting someone can be seen as like insubordination.
So bizarre.
Right? Because like, who are you to tell me I know what I'm doing? You don't know anything. Which I agree to an extent, but like, it's about growing that attitude. Even if what I'm saying makes no sense, even if the ideas I'm coming up with at tumor boards are stupid, it's like normalizing it and using it as an opportunity to teach that person, oh, actually, that's a good idea, but the reason it doesn't work is because this study. And then you're always going to remember that and you won't feel like, oh my God, remember that time I brought this up and I was like shamed and I don't even know why I'm wrong.
Yeah.
Or maybe no one knows about that study and you just taught them all something new. Like,
Yeah.
I don't understand why it's so shamed. I mean, I guess I understand why, and I know why. It's just frustrating.
Yeah.
But I think if you approach it from like a design point of view, almost like the way they design public spaces. If you put benches there with like that people can't lay on, then yeah, homeless people aren't going to sleep there, but then they're going to, I don't know, sleep in the dangerous alley and get murdered. Like, do you know what I mean? I know that's like really like oversimplifying, but you know what I mean? Like you can design.
It's that idea that like you do it with intent, you can have either very good outcomes, but you can also design things with intent that have very bad ones. So, but intent ultimately drives change.
Yes. So if it's like intentional, like, okay, I know tumor boards are really like annoying, and it's not about pimping. Like you're not going to be like shamed. It's not about like what's like set list criteria. And you're like, I don't know. It's more like using it as an opportunity to teach, instead of pimping, which is what like gynae. I hate gynae rounds. I don't go to them because it's just pimp session fest 2005. Like I hate it.
And like the other thing is people are not at their best when you put them on the spot like that.
No. And it's good to like learn how to be put on the spot because we need to for our exams, which I also think is not an equitable.
Yeah.
I mean, full disclosure, I have ADHD. Big time. I don't know if you can tell, but, the exam is not written.
No, it's not conducive to that. No.
For non-neurotypical people. It's like, it's hard for me. Like I know my shit and I was like, I'm going to fail this exam because I can't stop talking. Like I forget the question. Like, and they don't actually show you the question written out. They say it to you. And some of these are like paragraphs long. And I'm like, okay, can you repeat that? I don't even know what the beginning of the question was again. Like I can't physically remember because I'm ADD. Like, I'm trying here. And
the norm certainly does, like examanship as a whole never has catered to neurodivergency. It absolutely never has.
I hate the whole examanship idea. To me, like, it's like the pinnacle of what's wrong with medicine. It's so like fabricated and made up. It serves nobody. And it doesn't help patients. Like it doesn't help. It doesn't mean you're a safe practitioner. It doesn't mean anything. And yet that's what we fall, like, it's like giving someone an IQ test. Like it just doesn't, that was made for like a white man who's 30 in North America, like, but giving it to everybody in the world. Like it doesn't make sense. And I guess that's another example of like inequity and in medicine and not including everybody's like strengths. Cause like I remember telling supervisors when I start working with them, I'm like, you're going to be frustrated with me for the first month. You will be, like, please expect that. But I'm telling you, once I become like comfortable in your clinic, I will like be the best resident you've ever worked with. And you just need to give me time to like figure it out. Cause this is how my brain works. And you might think I'm like slow or stupid. Like, how did this person get this far in life? And then you'll see me like take off. And that always happens at the end of my rotations. I'm like, wow, you've improved so much. I'm like, no, this is what I always do. Like, it's how I learn. And, it was always like difficult to convince people that I wasn't just like making things up. So yeah, I think we all often don't give learners like that inclusive approach. Anyways, I digress.
No, it's super helpful. I will pause or I'll stop the recordings at this point. So my triplicate is going to all be stopped in a moment. Stop recording.